Welcome to another edition of the BR Ortho Podcast. Very pleased to be joined today by Dr. Kevin Riche. How are you?
I'm fantastic. How are you?
I'm doing very well. Thanks for asking. We already on this podcast had the opportunity to talk to the other Dr. Riche. We got the origin story of how you all met. I would love to see if the stories match. So
It may or may not. I don't know. I don't know how far back she went. The day I met her, or not the day I met her, the first time I laid eyes on her. Did she tell you that?
No.
So I was up in Boston at Harvard doing my fellowship, and I did like half of it at one hospital and half at the new hospital. And so I was rotating to the new hospital, and I had no idea where I was going. And I had previously worked with one of the other residents, and he was kind enough to show me around so I could learn where to go, And so he started with, hey, in the morning, the orthopedic team, we eat breakfast over here in the cafeteria. This is our table, So I said, okay. So I sit at the table, and we're eating, and she walks up with some of her people, and they sit at the table. And I thought to myself, there's no way she's an orthopedic surgeon sitting at this table. She's way too attractive. She must be like a dietitian or something. And because typically you don't see that many beautiful women in orthopedics. But that was the first time I laid eyes on her. But meeting was a different story. I don't know. I'll leave that one to her.
Let's go back and talk a little bit about how you got to that point. So you're from Baton Rouge.
Yep.
Yeah, and we know that you and I share a kinship, having both gone to Catholic High. At what point do you remember a point in your life where you decided or knew you wanted to either be a physician or do orthopedics?
Yeah, I have two stories on that, a childish one and then a more mature one. The childish one was when I was in the second grade. My older brother and his friends were playing CSAL football, and we had our little kids game going on the side, as I hope still happens in the world. But we were playing football, and my friend cheated, and I got mad. I punched him in the head, and when I did, I broke a bone in my hand, and I had to go to the orthopedic surgeon. Had to see my broken hand on an X-ray, then go through the process of multiple casts to get the bone to heal. And at that point, I knew that's what I wanted to do with my life. But then school and reality happened, and I wasn't sure I was going to be able to do it scholastically for a while until later on I got serious about school and matured a bit, and then I figured out I could do it. At that point, I got multiple jobs in the medical field and had a chance to work in orthopedics at Earl K. Long for years. And then I knew for sure. But I wasn't sure it was orthopedics. I thought maybe I'd be introduced to something else that I thought was really cool, that was even better. So I did autopsies. I did lots of different things, cardiology, EKGs. I did a lot of things prior to medical school and then rotated through everything in medical school. But there was nothing I found I loved as much as orthopedics.
So you didn't take the very direct path into medical school?
Luckily, I did. I didn't have to sit out years or anything. I did have 5 years of college. I was a NCAA Division II wrestler for a few years and got hurt. And after I couldn't wrestle anymore, I transferred back home to LSU. And during that thing, first of all, I had a redshirt year. Then with a transfer, lost some credit hours. So I had 5 years of college. But luckily, I was able to go straight from college into medical school.
Did wrestling maybe continue to sort of fuel that fire to want to do orthopedics, or to keep that in your mind that it had sort of the genesis of it was when you were a kid?
Absolutely, and I suffered through a lot of injuries and knee surgeries and things like that along my wrestling career, and so that absolutely fueled the fire. Absolutely. But in addition to that, I don't know if you know much about wrestling, but wrestling is a very disciplined sport. And I
Yeah, man. Stone Cold Steve Austin, The Rock, Hulk Hogan. I know tons about wrestling.
Yeah. No, the discipline to lose weight and to not eat, not drink, get on the scale, go wrestle, like do all the things you have to do in the real sport of wrestling. It takes so much discipline that I was able to carry that discipline over into scholastics to allow me to become a physician. I wouldn't have been a doctor without wrestling.
Yeah. So so when you're in medical school, at some point, I know this, that like every doctor, you have to pick, right? You have to choose what you're going to pursue. Did you ever consider anything other than orthopedics?
I did in that I rotated through all these rotations, again, keeping an open mind, thinking, hey, I might find something I like better. But when it came time to pick, I was all in orthopedics.
Hmm. And so you end up in Boston for your fellowship. Uh, when whenever you finished that fellowship, what was the decision process that led you back ultimately to Baton Rouge and to Brock?
Well, I always wanted to come back to Baton Rouge. I'm from here. I love the community. I love the people. I love the culture. I love everything about Baton Rouge. And so you do residency before fellowship. So at the end of my residency, I was already interviewing and things like that for jobs in Baton Rouge. And so by the time I even left for my fellowship, I already had a job back in Baton Rouge. And you know, that evolved over time. Initially, I was actually at Bone and Joint. I was there for 2 years and then switched to Brock. And that switch was 15 years ago. But
Mhm.
but I've been very happy with being back home, and Brock is in my opinion, just a phenomenal group.
What's the appeal of being at Brock? What do you enjoy so much about being there?
Everybody you work with is really good. I mean, we have a group of guys and girls that are just amazing at what they do, and just so you have an issue with a patient, you just walk down the hall and grab your partner, and you know that this is one of the most skilled guys or girls that does this anywhere in the country, and you know that you're the person you're handing your patient off to is going to be very well cared for.
Yeah. Um, you know, the we're going to talk about a lot of different focuses that you have and specialties that you have. I want to start with hips though. Uh, what what ultimately was the appeal that led you to that as sort of a focus? And am I correct in saying that that's your subspecialty?
Yeah, and that's actually fantastic to start with that because my practice has really evolved over the years. I did my fellowship in trauma. And in the first many years of my practice, I did mostly trauma. And trauma is one of those fields that people don't really understand. It's not as easy to understand as I'm a hand guy, right?
Hmm.
Trauma is really difficult, shattered bones anywhere on the body. And what I loved about trauma was that it kept me really good at all the parts of the body with the anatomy, with being able to operate on these things. But within trauma, there is one body part that's only trauma, and that's the pelvis. And the pelvis has the hip cup in it. Okay. The name for that is the acetabulum. But the hip cup is part of the world that is trauma guy. We're the masters of that. So that in essence makes me a hip specialist. And
Hmm.
so then later, when I evolved and started doing less trauma and more um, elective type stuff, it still kept me in the world of a hip specialist, and so that's how I got really specialized in the hip.
When I think about hip injuries, or maybe the most common thought of a hip injury would be an elderly person falling and breaking their hip.
Mhm.
Is that the most common form of a hip injury?
It's certainly a huge number, and we deal with a ton of that, but we also deal with young people who have either sports related injuries or things that aren't even injuries, things that are just the way your hip anatomy is, it predisposes you to having a problem like
Hmm.
what we call a labral tear, which is a situation where you tear some of the tissue that surrounds the hip cup, and you can do that just by doing you know it's not really an injury. It's kind of an over. You do a lot of sports, you do a lot of motion, you do a lot of things, and then you develop problems with. And so there's a ton of that out there too. But yes, elderly people falling and getting hip fractures is a huge thing, and you don't treat those all the same. Some hip fractures you're able to fix the hip fracture and get it to heal, and then other types of hip fractures you have to do replacements for.
So are fractures not even the most common injury that you might deal with?
Um, Probably injury wise, it probably is the majority, but there's some close, things that are close to that injury wise. I see a lot of hip strains. I see, But I also see a lot of arthritis in the hip
Mm.
that's, not a fracture, not a injury, but more of just wear and tear and somebody's having hip pain. And then there's also bursitis and things like that that we see around the hip. And then the other very difficult thing about the hip is that what is hip pain? To some people, hip pain is pain in the groin. To some people, hip pain is hip pain out here. To
Mm.
some people, hip pain is kind of their butt. And
Mm.
so when a patient comes in talking about their hip, that could be a low back issue. That could be all sorts of things. And so figuring that out is part of the difficulty of dealing with a hip
Yeah.
situation.
Um, it's interesting because just as you were sitting there and sort of demonstrating, I'm thinking about how I'm sitting right now, and I'm probably pretty contorted. My spine, my hip is, as I'm kind of like leaning in the chair toward you. Is this a common problem for? I would imagine, right? Like, because most of what a doctor would want to do, I would think, is okay. How can I prevent you from having to come see me and having issues in the problem or in the future? How much of it is this people like me who has a desk job and I'm sitting all day and sitting like this?
Sitting does cause a lot of issues.
I'm going to straighten up first.
And it's not so the important part is moving, all right? Like switching your position is very important, so you're not putting too much pressure in one spot, too much stress on one spot. So moving is very important, but that's not just how you're sitting, that's also getting up and moving. As we sit all day, our hamstrings are shortened because our knees are bent.
Mm-hmm.
And when you stand, your hamstrings are being pulled on. And so if you sit all day and never pull on your hamstrings, they get shortened. And then that gives you all sorts of issues. Public service announcement to stay out of my office would be stretching, stretching, stretching.
What? So, are we talking? I wake up in the morning and I bend over and touch my toes a couple times. Do I commit a certain amount of time a day? Different times of the day?
Great question, and I think the answer is do what you can. I mean, obviously, if all you have time for is to bend over and touch your toes every day, at least if you do that and the other guy next to you never does that, you're going to be a lot better off than that other guy in the long run as far as having issues with tendonitis and things like that. But certainly if you can put some time to not only stretching bending over and stretching the stuff in the back of your leg, if you could also take some time to stretch the stuff in the front of your leg, that would be even better, right? So obviously we all have difficult lives and schedules, and so you can only do what you can do. But if you can stretch, it would really help.
Yeah. When you do see hip injuries, how how does how do you go about treating people? Meaning, obviously, it's going to depend on what the injury is, but at what point are surgical interventions necessary? At what point are there other options for people, depending on what they're dealing with?
That's a difficult question to answer, but what I can tell you is that the first thing I do is evaluate a patient in the clinic and see what part of their hip is causing their hip pain, all right? And so if it's one of these hip strains or bursitis or something like that, usually an injection or maybe physical therapy is the way to go. And then certainly if you have a patient that consistently is just not getting better with the conservative treatments, then I think at that point we get better imaging and we make sure there's nothing else going on, or we find what the real culprit is, and then we target the treatment to that. And again, that treatment may be conservative treatments, or there may be something that's you can do all the therapy in the world. It's not going to fix this problem if you either need to live with it or have the problem fixed surgically. And so, I mean, that's kind of how you get there.
Yeah. I want to talk about joint replacements because replacing a hip feels like something that does commonly happen. I would think hips, knees.
Yeah.
Why is it? Why is that? Maybe am I right in saying that hip replacements are one of the more common joint replacements?
Yes.
So why is that a common problem?
Well, there's a lot of reasons you can end up with a joint that's worn out, but when you get to the point where the joint's just worn out, there's really nothing we can do other than, we can try some injections, we can try some different things, but ultimately when the cartilage is worn down and you've got bone rubbing on bone, that just hurts, and there's nothing else we can do to fix that problem other than a joint replacement. But the hip joint replacement is the world's most satisfying surgery, not only for doctors, but for patients and everybody else. Like of any surgery, of any field, hip replacement is the most satisfying surgery. So, our knee replacements aren't as good, or, nothing else is as good as a hip replacement. It really works, and people are generally extremely happy with them. Um, so we replace people's hips when they need it, and generally that's a good surgery.
You just in, let's say, 15 years. That's how long you said you've been at Brock, thereabouts, but 15 years. How far have the advancements come in joint replacement just in 15 years?
It's been good. It's been really a lot of advancements. In the hip specifically, for me in my practice, there's multiple approaches to the hip. And what I mean by an approach is how we actually get down there. And the more in vogue new way to do it has come about in about that time frame, and that's called the direct anterior hip approach. And so that's been a huge advancement. And then there are some technological things with the components themselves that have been major advancements.
And what does that mean for the patient?
So for that direct anterior hip approach, what that means for the patient is a little bit smaller incision, but we don't have to cut any muscles as compared to the other approaches. We actually like move the muscles over and we go between them, and that makes the surgery actually technically more difficult, but the result is fantastic. The patients can get up out of bed almost immediately without nearly the pain, and they don't have to fight so hard with therapy to get their strength back and things like that. So the recovery is way better with the direct anterior approach.
Less pain, less downtime, quicker recovery.
Yeah, I mean, I have some patients that are playing golf at 2 weeks, and not everybody, but
Sure.
but some, and they're very happy. I don't always use the direct anterior approach. It's not appropriate for everybody. Some people's body size it's not going to be possible, or if they have certain types of hip situations, we may have to have a more utilitarian approach. We might have to do something a little bit more involved. It may not make you a candidate for it, but most patients are, and it's really, really good approach.
One of the things that I've certainly learned in being able to host this series, talking to a lot of different doctors from a lot of different specialties, while you may have a subspecialty, every doctor kind of does or is capable of doing everything, doing a lot.
Yeah.
Aside from hips, where else do you focus? What else do you see mostly?
See everything in clinic, and I
Sure.
love seeing everything in clinic. I mentioned earlier I love general orthopedics, and that's why one of the reasons I chose trauma was to keep
Right.
me focused on all the parts. And so I see everything in clinic. I love that. I love seeing little kids with problems. I love seeing old people with problems, and athletes, everybody in between. But to answer your question, I do kind of a lot of different things. One of the things, going back to my trauma roots in the pelvis, is that I used to fix so many pelvic fractures that that's in my wheelhouse big time. And so I've taken that and started to do other things in the pelvis. And one of them is something called the sacroiliac joint, the SI joint, if you will. A lot of people have a lot of problems with the SI joint, and not that many doctors are really noticing that and focusing on that, but I am. And so one of the things I do for patients that need it is I fuse the SI joint to take their pain away. And it's really a great surgery. I've been doing it for probably about 10 years, and but still doing that same type of work for about 20 at this point. But ultimately, it's an incision this big where I put some implants across the SI joint. It takes me about 20 minutes, and it really works well for these patients. Now, we don't start with that. We start with conservative treatments, physical therapy. There's actually a belt that I use to try to help these patients with their SI joint pain. And then I always get an injection in the SI joint. The injection helps in a few different ways, and I think this is pretty neat and important. And that is, there's 3 things that are injected through this needle. One of the things is lidocaine, which is numbing medicine, and that's going to numb the joint, and that's not going to last very long. But if the pain is coming from that joint, it's going to numb it, and the patient is going to have relief of that pain. And that's incredibly important because SI joint pain is not super easy to tell on a physical exam. This pain could be coming from the back, it could be coming from the hip, it could be coming from this. And so it's not crystal clear. This injection helps make me clear it up. So if the patient right after the injection has a bunch of pain relief, we know we found the culprit of their pain. The second thing that they inject in there with this is a little bit of contrast so that we can x-ray it and prove that we're in the joint, because we don't want to think we're in the joint and numb the joint and their pain went away and then find out, it wasn't actually the joint that we thought it was causing the pain. It was something else. So we'll want proof that we're in the joint, and then we want to numb the joint and see how that patient does. We call that a lidocaine challenge, meaning challenge it to see if that's the culprit of the pain. The third component in the injection is your typical cortisone that we use. And the hope and prayer there is that when the lidocaine wears off, that cortisone is going to kick in and give that patient long-lasting relief. And then hopefully they won't need a surgery. They'll just, have the relief from the injection, and maybe that lasts them a couple of years or something, and then we just repeat the injection. But for the patient that is having a lot of SI joint pain and nothing else is relieving it, they have injection, and the injection knocks out 100% of their pain or 90% of their pain or some high number like that, the fusion can give them that same relief for a lifetime.
So I know you brought a model. Could you show me the SI joint and exactly what you do?
The reason I brought the model is because talking about an SI joint, most people have no idea what you're talking about. And so I think being able to visualize things, at least for my brain, it helps a lot. So I brought this model in. This is a model of the pelvis. And the sacroiliac joint, or the SI joint, is this joint right here that goes between the tailbone, which is the sacrum, and the pelvis, which is the ilium. And so that's what we call the sacroiliac joint. And this joint can give patients a lot of pain. And so, again, we inject it by coming through here and injecting the joint and find out if that's the culprit of their pain. And again, if they're to the point where it's bad enough to consider surgery, what I do is I make an incision about that big on the side of the hip. And similar to how this model is put together, it's got these two screws right here that are holding the pelvis to the tailbone. That's similar to what I do in surgery, although I don't use screws. I use an implant that looks like this, and it's triangular, so it has rotational control as opposed to a round screw. And I usually put 3 implants across here. And what they do, if you can envision them going across this SI joint, is that the bone on this side heals to this implant, and the bone on this side heals to this implant. And that takes the motion away from the joint. And so it's a minimally invasive way to fuse that joint. And this implant is made with an incredibly porous or rough coating. And so that's the same size as our bone pores. And our bone wants to grow onto this implant and through these holes. And so it's very effective.
What's interesting listening, I think sometimes the perception is that surgeons want to operate. I mean, that's what you do. You're highly skilled and trained surgeons. And you maybe have a feeling that you want to go fix people. But what I'm hearing is there's a long process of let's avoid cutting if possible.
So I think that's the way it should be. I mean, and I'm hopeful that other doctors feel the same. But I'm probably one of the more conservative ones. But yes, I reserve surgery for when everything else has failed.
So if it's a knee or a hip or a knee, for example, you mentioned trauma, doing everything. What sort of things do you do in the OR for people with knee pain? Or what options are there for people with knee pain?
Well, I'll just tell you the different things I do surgically for knees. I do like knee arthroscopies for like meniscal tears and things like that. I do ACL reconstructions for people who tear their ACLs. And I do a lot of knee replacements, which brings to your question. I do a lot non-surgically for people who have arthritis in the knee that may be eventually going to end up with a knee replacement. I try to treat those all non-surgically, and I usually do so for years by the time we get to knee replacement. And there's a lot of really conservative treatments, but when the arthritis really gets bad, the first real thing I think is effective is a cortisone injection in the knee, and that can give patients years worth of relief. And then if that starts to fail, then there's 2 other types of injections I use in my practice. Something called viscosupplementation, where we inject hyaluronic acid into the knee, and that kind of relubricates the knee. And then there's a third injection I use called Zilretta, which is more like a cortisone, but it has a time release component and it tends to work longer. So I bring patients through all of that, and then if all of that fails, then I think you're going to be looking at a knee replacement.
And I know we've talked a little bit about advancements. What types of um, options do you provide specifically for patients that might vary or differ?
Conformis, and Conformis is just the brand name, but it's ultimately a knee replacement system where we take a CT of the patient from their hip all the way down to their ankle and map out their anatomy. And then from that CT, the computer calculates exactly what angles we should make the cuts in the surgery and how much bone to remove. And then they make a component specific for that patient that's going to fit their knee perfectly. And that all gets done with incredible precision by a computer, and then they make these guides that fit on the patient's bones that have a slot for my saw blade, such that if I put the guide on right, we're going to be making the perfect cut. And then the knee fits perfectly, and then it gives us a perfectly aligned limb. And I think that's incredibly important, but I think about the tires on your car. If your alignment is off, your treads wear quick. If your alignment is perfect, your treads last a lot longer. And I think that's incredibly important in joint replacement. And so that's the technology I use most of the time. I know that you advertise for, or have in the past at least, for the robot.
Mm-hmm.
And I am certified on the robot as well. I think the robot's got similar technology. I like the Conformis a little better because it cuts down the operating room time. The robot, you have to do all that stuff in surgery. This is all done before surgery.
So you're talking what amounts to a custom implant that's made specifically for that patient to fit that joint is made to fit their body perfectly.
Yes.
That's what I think there's a very obvious benefit that I would assume, but I want to hear it from you. What is the benefit, obviously, to a patient of having a custom joint?
So the company actually makes two options, and that's historically the option that we've been doing. Some hospitals, not so much around here, but in other parts of the country, are starting to have issues with that because it's a more expensive implant. And so the company has come up with a second option where everything I said technology-wise is the same as far as all the cuts and the guides that give me the precision to make me an incredibly precise surgeon and make the cuts perfect. But instead, they take that CT scan and they say, well, this person, their shin bone, their tibia, it's going to fit off-the-shelf size too really, really well. And then, we're going to customize to their femur. We're going to choose a 3 or whatever. So they have their custom-made implant, and then they have their customized implants. And the reason that they did that was just for price, because the custom-made are more expensive than customized or not. But to answer your question, intuitively and marketing-wise, we would think that the custom implant has got to be better. In fact, I'm not so sure. I think what's so important is the technology going into helping us make this limb perfectly aligned and making the cuts at the exact perfect angles and making those guides to fit custom on their bone to allow me to make those cuts perfectly. I think that's more important than the actual implant being specifically made for the patient or customized to the perfect size based on their CT scan. I don't think that's a huge difference.
Okay.
I think the technology in the surgical precision is really the key.
You also mentioned in the knee that you do ACL reconstruction. Now, I'm a sports guy. You mentioned you wrestled. It's one of those common things we hear, right? When you hear about a player tearing an ACL in whatever sport. But also just in our lifetime, ACL reconstruction has come so far to where we see athletes come back into their sport certainly inside of a year. I think of, we're obviously in Baton Rouge. Think about Joe Burrow, the injury he had in Cincinnati, where he suffered that injury in December or November, and was back in September for the start of the season. Why? What has happened with ACL reconstruction that's allowed that recovery time to shrink?
A couple of things. One of them is that we've learned a lot over the years using different types of graft to make that new ACL. We've had some older ways to do it and switched to some newer stuff, and then found that it wasn't quite as good as some of the older stuff. Then we found some newer stuff that's even newer, and so one of the things is the graft strength. Okay, and I've recently switched to a new way to do it, which is using the quad tendon as the graft. I have had both of my ACLs reconstructed.
Mm.
In the early 90s, they used what they call bone patella bone, where they cut part of your kneecap, part of your patella tendon, and part of your tibia to use the graft. And that was very strong. We switched, and I had this one done, let's say 12 years ago ish. And there we used hamstring tendons. And hamstring tendons are easier to harvest, less pain for the patient later.
Mm.
And we thought pretty good and pretty strong, and they work great. I mean, mine's working great, but we found in the people like Joe Burrow or maybe offensive linemen or stuff like that, that the bone patella bone was maybe a little better because it was stronger. So now we've come up with this way to do it through the quad tendon, where we don't have to harvest that bone and give that extra pain, but we have a much stronger graft, more similar to the bone patella bone. And easier to take and less morbidity, kind of like the hamstrings. And so, to answer your question, one of the things we've done is figured out stronger graft. The second thing we've done is better techniques for fixation on each side once we put the new graft in. And the third technique is therapy. When we put a new graft in, we have to protect that graft long enough for it to become strong and healthy again. And if you really strengthen the surrounding muscles, you can kind of protect it better. And so those are the things that have allowed us to speed up the time. When I was a wrestler and I had mine in the early 90s, they made me sit out of wrestling for a year. When I had my other one a few years back, I was back to skiing in 6 months. And so It's the difference.
That's incredible just to think, because also just think of the age difference. Yeah. So if you were talking, in your late teens, early 20s, you had to be out for a year, and then later in life, on in your professional life and adult life, you were able to recover very quickly. You would think it would be the opposite, right? You would recover more quickly as a young person.
The other part of it is we're pushing the envelope a little bit more, and I think that's a thing, and especially professional athletes. We're gonna help them. They need to get back on the field. There's a lot of money at stake, this and that, and so we kind of push the envelope a little bit more. If we're talking about a weekend warrior, maybe stay out a couple of extra months, give that thing time to heal.
Yeah. I know in your practice, something else that you do and treat differently or collarbone, clavicle injuries. When I was when we were kids, I have a brother that's 16 months older than me, and brothers fight. And there was a time where I stole my brother's bike. He was on rollerblades, and we played street hockey. So he was on rollerblades, and he tried to throw the hockey stick between the spokes of the bike, so I couldn't get away. And on his rollerblades, he just went, head over heels there, and broke his collarbone. And this has been 30 years now, and so I'm curious what has changed, because I remember seeing the bone, like on top of each other. Well, I'm curious what's changed.
A lot's changed. People have been breaking their collarbones since the time of cavemen, and
of course,
and nobody was doing surgery on those guys, and they weren't dying, right? So the pendulum is swung, and now we operate on a lot of collarbones. And so the great question as to why and what's changed. And what we found through our studies is that if the bone is broken and it's shortened more than a centimeter, that your muscles aren't going to be held out to their appropriate length, and you're going to lose some strength and power. So that's one reason or indication to consider surgery. The second one is if the bone is displaced greater than 100%. So if the bones are so far apart that there's too much space in between, that they're probably not going to heal back. Mm-hmm. And that's a thing that really did happen to a lot of collarbone fracture patients. They would go into what we call non-union, where the bone didn't heal. And they wouldn't necessarily have a bad outcome, because they'd get back to where they could move without pain, and they'd have some less strength and things like that, but they would do okay. But once we figured out that, man, if we fix those, then they'll have a much higher chance of healing. So this is where it evolved from. But yes, we operate on a lot more collarbones than we used to, but we still don't operate on most, but yeah, so when we operate on them, it's going to be the majorly displaced ones or the really shortened ones. Or there's some patients who just adamantly want to get it stabilized so that they can get back to doing things quicker, and that's another indication.
Is there a disparity between certain injuries when it comes to pediatrics and adults, things like that?
Yes, the criteria for that kind of thing is different because kids, especially young kids, they just have such a more intense healing capability. So they're going to heal a fracture that maybe an adult wouldn't. And so we have different kind of criteria for depending on your age.
Yeah, so I would imagine that's how you would advise a parent. So if a parent's watching, listening, and their child has some type of injury, obviously the first thing is come see the doctor, be seen, and most parents, every parent of course would, um, those conversations with parents on options, how do you typically walk parents through that?
Well, I do exactly that. I say these are the advantages of treating it conservatively, and these are the advantages of treating it surgically, and these are the reasons why we would even consider surgery, and I just let them choose. And again, I'm pretty conservative, so I'm going to tend to err towards being conservative.
Yeah.
And when having that discussion.
As we talked about a lot in the 15 years since you've been at Brock, and even just some of injuries you had when you were a wrestler, when you start to think ahead, what the next 15 years with medical advancements, or even 5 years, like what that looks like, what are things that excite you about orthopedics now, and what's being discussed or studied or in practice?
I don't know. There's a lot. I mean, I don't know how to give you a great answer there. We have biologics is something that we talk a lot about, which is basically trying to figure out, how to manipulate genetics and stem cells and different things like that to allow us to treat patients in a better way. And we're not there yet, and I don't think we're going to be there in 5 years. But that's probably the most exciting thing on the horizon.
Yeah. Do you see those types of advancements in our lifetime?
I hope so. Yeah.
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 I could tell you have a lot of passion and excitement for what you do. Do you still feel the same today? Like you still as energized today, going to the OR, meeting with patients as you've ever been?
I think so.
Yeah.
I think so. I really love what I do. And not to sound too corny, but I've been blessed to be able to do what I do, and that makes me excited on a daily basis.
We appreciate the time today. It's been a pleasure.